think my interest in disordered eating began a long time ago, actually. I was an athlete growing up. I was a competitive swimmer from middle school all the way through through college, actually. And I think, being a competitive swimmer, I was always really interested in, health and wellness, nutrition, those kinds of things. But I found myself always really struck by, I was constantly surrounded by incredible athletes with incredible, bodies that were able to do amazing things. And yet people often talked really negatively about their bodies and were always trying to pursue looking different than they did, weighing different amounts than they did. And often kind of their pursuit of those things actually made it harder for them to achieve what they could have in the pool. And I just was really struck by that. These people are kind of at the peak of physical performance and how they could be still so caught up in body image in a way that felt surprising to me. And then in college at the same time, I was studying dietetics, so to become a dietitian, and that's a field that's really fraught with, a lot of assumptions and stigma around kind of how you should look and what you should or shouldn't eat. And yet, I know nutrition matters, and I know that what we eat matters. And so really became interested in this idea of how do we help promote health without promoting health to such a degree that people become overconsumed with how much they weigh and what they're eating. And so I think that's what really drove me. I mean, it's I followed this meandering path, right? I became a dietitian. I worked for a while in an eating disorder treatment facility as a dietitian, and then came back to school to pursue my PhD, and that was in epidemiology. Always been interested in public health. And so I think what really, what this kind of comes down to for me is being able to think about, how do we appreciate the fact that what we eat matters and what we eat does have a really big impact on our health. And yet a component of that is also our mental health, and that it's both thinking about how we eat and how we can use that to kind of maximize our physical health, but not to the detriment of our mental health. And so what I'm really interested in now I've continued to research younger and younger kids is how do we first begin to form this relationship with food and first begin to form the relationship with our bodies, and what are the things in our environment, parents, coaches, teachers, doctors, who influence that narrative that we begin to have inside our own heads about am I a good eater? Am I a bad eater? Do I have a good body? Do I have a bad body? And how do we help kind of promote the positive without inadvertently promoting the negative? Yeah, so I have been a member of the Academy for Eating Disorders since I was a doctoral student. I guess probably way back in 2009 was when I first joined. And I've been involved in the organization, as an early career investigator, I guess as a student, as a postdoc, and then an early career investigator. And have taken on various leadership roles during my time. So it means a lot to me. I mean, I think about this as this is my academic home, and I'm getting the highest honor in that academic home. And it's an international organization. And so this means that I'm being recognized by colleagues both, in the US and around the world for my commitment to research and clinical practice in this area. So it's a big deal. I think, a lot of my leadership in AED has centered around bridging the gap between research and clinical practice. So it's an organization that has a lot of clinicians and then a lot of researchers, but there's not as many people who are doing both. And so I've really tried to kind of bring that lens of how do we come up with questions in a clinical space and then research answers to them, and how do we use the research that we do to inform the clinical practice that we engage in, and kind of making sure that those things are moving back and forth and not siloed. And then the other lens that I think I bring that's really unique is the public health and primary care lens, right? A lot of folks who are in AED are in eating disorder specific clinical settings or eating disorder specific research groups where they're really in the weeds around disordered eating behaviors and eating disorders. Whereas I really think about this from a public health lens, how is all of the things that we're doing to promote health and well-being for people, how can we transform all of those to be done in a way that's protective against the development of eating disorders? And so I think looking forward, I hope that I continue to lead in both those areas, kind of bridging that gap and then bringing that kind of public health or prevention-based lens to the work of the Academy. One of the biggest things, especially kind of in the primary care world that we're in, that I think needs to change is this assumption that eating disorders are really rare. I think in med school, people learn, the real small prevalences of anorexia or bulimia nervosa, and they think this is not something that I'm going to see as a family med doc. And really, what we know is that I keep using the phrase disordered eating behaviors, and this sort of encompasses all of these behaviors that are disordered, but may not meet that threshold for a true clinical diagnosis. Or it may mean someone who's engaging in all of these behaviors, but just never makes it to a facility where they receive that clinical diagnosis. And we know that the prevalence of these behaviors is really high, actually, right? So when you're in primary care, when you're a dietitian, when you're behavioral health folks, if you're a family medicine doctor, like you are seeing patients who are engaged in disordered eating behaviors, probably daily, weekly in your clinic. And the behaviors kind of range across, they impact people of all races, all ages, all socioeconomic statuses. We've actually begun to learn a lot about the impact of food insecurity on the development of disordered eating. And so sort of dispelling the myth that these are rare or that they only impact a certain type of person, I think is one of the biggest changes that we need to see. Because once we begin to recognize like these are in my office, then we start to ask the questions about how can I be sure I know when my patients are facing them, what can I do to prevent, how can I screen, and when do I need to refer, right? And those are all the things that we need to be asking in primary care to make sure that we're doing right by our patients. One of the first things to know is that they're so new, there's so much we don't know, right? And so I think this is always true of science, that like an answer that you have today may not be the answer that you give tomorrow or the next day, because hopefully we're continually researching and continually learning, and that's kind of how we grow as scientists and as clinicians. But I think kind of at this point in time, I think one of the things that I really think is important is when you're meeting with a patient who might be considering a GLP-1, that you're thinking about truly informing them of what the medication does. So a lot of the ways that the medication works in our bodies are to kind of have an impact on hunger and fullness cues, have an impact on, how often you're driven to eat. And so changing some of these things about the way that our bodies react to and have a drive for food can trigger an eating disorder, or can exacerbate underlying disordered eating. And so I think for me, true of every patient that comes in your door, I think having an understanding of past history and current use of disordered eating behaviors is key before you're making any type of diet advice, weight loss advice, certainly, right? And I think that's even more true with GLP-1. So knowing whether your patient is at high risk and having that conversation with them is critical. And then I think, what I call kind of true informed consent, right? It's not just like, hey, do you want to take this medication or not? This is available or not. It's like, what does the medication do? How does it work? What are the risks? What are the benefits? And kind of what I talk a lot about expectation management. Like, what can you expect from being on this medication, and how does that fit with what you're looking for? And and what will and won't it change about your life and your body, right? So I think a lot about eating disorders and disordered eating is a desire to change one's body, and some of that then leads into kind of because you feel like this or that will happen when you experience those body changes. And so really trying to dive in to that, some of those expectations with your patients to make sure that the things they're thinking are going to happen are realistic for them. And likely to happen if they take on the medication, and that they have an understanding of that and the risks that come with it. So I think that, and kind of real careful monitoring and following up to be sure that somebody is tolerating it well, is critical as well. So I think, potentially helpful for some, certainly not appropriate for all, and need to be prescribed with a lot of caution and a lot of support. So, I mean, I think one of the biggest things that I spend a lot of time talking to people about, both in clinic and then when I do resident education, is trying to kind of pull apart this idea of health and weight. People can exist at a variety of weights and be healthy, and people can exist at a wide variety of weights and be unhealthy, right? So we can't really look at somebody and see their weight, their shape, their size, or look at a growth curve, for example, and know much about their health at all, right? And instead, what we really need to begin to understand is the behaviors they're engaging in. And so I think I tend to talk about using a weight-inclusive approach in my clinical practice, and do a lot of teaching about that approach. And what that means is, really trying to kind of, I'm not making the goal of changing somebody's weight when they come in the door of my office. I'm not centering weight in the conversation when they're in my office at all. It's really about what are the behaviors that we know lead to healthy outcomes for people. So things like nutrition, physical activity, stress management, sleep, relationships, right? And so if somebody has all of those things kind of in good working order, right, then the health outcomes are going to come from that. The positive health outcomes are going to come from that. And if somebody has an imbalance in one of those areas, then working with them to address that behavior, right? Like, how can we help improve your nutrition? How can we help get you more active in a way that feels good to you? Because any changes that you can make to sort of improve those behaviors is going to lead to a positive health outcome, regardless of if you change their weight, right? So it's not about doing those things to make the weight go up or down. It's not about looking at someone and saying, hey, your weight's fine, who cares what you're eating, right? It's about thinking about how do we know, how do we check in with our patients about each of these behaviors and then work with them to sort of maximize those things. That's one of the biggest things that I try to focus on, in my clinical care and in my teaching is keeping the focus on that. And I guess the other thing that you talked a little bit about is weight talk, right? Like, how are we having conversations about weight, about celebrities being too big or too small, about family members being too big or too small, about going home for the holidays and having people comment on weight loss or weight gain. I mean, I think one of the most harmful things that we can do for ourselves and also for our children, for the people who are in our presence, is make those weight-based conversations a part of every day. And they are a part of everyday culture in the United States. And so really thinking about how we can begin to not have those conversations ourselves, and then how we can think about shutting them down. In particular, I do a lot of work with children, in particular around our kids, and making sure that we're just focused on behaviors, not bodies.